It's important to understand this transeptal puncture is more than 6 or 7 decades old. Like everything else, the initial investigators struggled in the basic sciences lab to go back to the anatomy and design their catheters. Dr. Ross and Morrow and Braunwald at NIH in 1956 performed the first transeptal using a Conard catheter. The needle was brought up by broken barrow, and an atraumatic sheath and dilator sheath was designed finally by Dr. Mullins. First and foremost, before you doing a transeptal, you should understand what are the challenges. If you have a septal thrombus or something sticking around the septum, interatrial septum, then it's a strict contraindication for transeptal procedures. The relative contraindications where you may find little difficulty, but it can be overcome, or patients with distorted anatomy, or patients who have a very enlarged left atrium or right atrium, very enlarged aortic root. This is common in elderly patients where the root of the aorta is dilated, or in patients with aortic regurgitation or aortic stenosis, bicuspid aortic valve. They come back for procedures, the aorta will be very dilated. Interrupted IVC, post-ASD patch repair, and there are ways of going around this. So very rarely, if you may have a very floppy septum, the septum will stretch and stretch as the needle is pushing it. It won't yield. So you need to have a very sharp needle, hold the tension, and then puncture. We'll come back to this. When multiple transeptal procedures are done, sometimes the area becomes fibrosed and maybe a little challenging. First and foremost is to familiarize with the hardware, then look at the anatomical landmarks and use intraprocedural imaging, whether it's fluoroscopy or echo, to guide your puncture. It's a very neat system where the sheath is approximately 59 centimeters. The dilator, the black dilator, is about 8 centimeters longer than the sheath. So it's going to protrude out of the sheath. About 8 centimeters will be beyond the sheath. The needle tip is 2 centimeters longer than this dilator. So when you actually push the needle into the hub of the dilator, only 2 centimeters enters the left atrium. So that's the beauty of this. Throughout the procedure, you will have the needle withdrawn about 2 centimeters inside the dilator. So again, the needle has an indicator, an arrow-like indicator, which points, which is in the same direction as this tip. So if you move this clockwise, this will move posteriorly in the plane when the patient is lying down. And this is, suppose this is on the thigh. And if you start clocking this so that this moves posteriorly, the needle tip will move posteriorly. When you counterclockwise, it will move anteriorly. So you try to use this movement to direct the site of puncture. And inside this needle, when we want to take it in atraumatically, what happens is a lot of people blame the needle. The needle has a beveled tip. If you directly put in the needle inside the dilator, there is a small risk of scraping the interior of the dilator. How you prevent this? You just take a needle and there is a stylet. You see the needle is here, the stylet is here. The stylet is 21 gauge. So it's thinner than it goes to the central lumen, goes all the way till the tip, and goes beyond the needle tip. When you introduce the whole assembly, it's important to introduce it with the stylet. So the stylet should be inside the needle, and this assembly should be introduced inside this dilator. Then what happens is you won't get anything inside the lumen of the needle. So when you make a puncture, there won't be a plastic material, nothing else. So this is how it looks. When you have the, as I told you, there is about 8 centimeter of the dilator. When you see, this is the hub of the dilator, hub of the sheath. The direction of this, the irrigation port tells you the direction of the curve of the, it's in the same direction. It tells you it should be aligned and it should be medial. So then you take the dilator inside, and when you plug it inside, there'll be a clicking sound. That is when it's fully docked. If it is not, sometimes there'll be a disengagement. So make sure this is firmly pushed inside and locked. And then you advance the needle with the stylet and make sure, if you have it generally about 2 to 3 finger breadths here, you shouldn't push it all the way in. Make sure that the needle tip stays here so that inadvertently it shouldn't scrape the visceral organs as you enter. Only when you bring it inside that length, it will start puncturing. So this length between the dilator tip and the needle tip should be maintained constantly throughout the procedure. Only when you are about to puncture the correct side, you fix the hub of the dilator and the sheath on the left hand and advance the needle with the right hand so that you enter the left atrium. Now, this is what I meant. Suppose this is the patient's femoral area and you're operating. This is 3 o'clock position when the hub is like this at 3, 4, 5, 6 o'clock position. In smaller atria, when you have the needle, this flange tip pointing at 4 o'clock, you'll be engaging the septum very well. In larger and larger atria, the right atrium enlarges. You need to block it more so that you engage the septum. And the BRK needle has a bevel there, and it's better to have the dilator all the way inserted. So let's look at the septal anatomy, the gross anatomy. This is superior vena cava. As you withdraw the assembly, you'll find that the whole assembly falls medially. And then as you withdraw the assembly further, there'll be another movement medially. That is when you engage the septum. So in right anterior oblique, the septal puncture, this is the root of the aorta. Roughly the His catheter will be located here. To mark the root of the aorta, we sometimes take a pigtail, rotate the pigtail counterclockwise location so that it is positioned in the non-coronary cusp. If you are very particular, if you are uncertain, puff a little contrast and make sure it is on the posterior most aspect of the aorta. This is the anterior portion of the aorta where the left coronary cusp comes in, and this will be the posterior aspect of the aorta. You need to position it both. You can check it in RAO and LAVO before the puncture. Generally, the site of puncture will be around the fossa. If it is for pulmonary vein ablation, we generally puncture it in the anterior inferior location. If it's for a routine anterolateral axillary pathway or an anterolateral papillary muscle or a very large LA, left atrium and left ventricle, as in patients with old MI, you want to ablate VTs in this area. If the puncture is here, you can't reach this area very easily. So we make a slightly superior puncture. For post-infarction VT in the inferior wall, we make a slightly inferior puncture so that it can reach this area. In left anterior oblique, the sheath and the dilator should point posteriorly, but it should be slightly inferior to the lower margin of the aorta. So the needle comes in different curves. The BRK needle is the one that we use generally. It is a slightly about 90-degree angle, that is this angle. But if you want in a very large right atrium, you bend the needle, or the needle BRK1 has about 50-degree angle, and that is well positioned to make the puncture. You should understand before you puncture again, I'm reiterating, the sheath length is 59 or 63 centimeters. Dilator length is about 4 centimeters longer, and the needle length is 71 centimeter. And there is a stylet that is inserted. When hubbed, the needle leads the dilator tip. Generally, the procedure is done from right femoral vein. Rarely we use when the right femoral vein is for some reason not obtainable. Previous procedures, sometimes it's partially occluded. You can go from the left. Patients with interrupted inferior vena cava have IVC defects. Access can be obtained from IJV also, jugular vein. Now, to guide the procedure, what we do is initially we advance the wire all the way to the left innominate. You can see the wire going above, taking it always towards the left innominate. Very rarely, if you have any difficulty in positioning in left innominate, you can take the help of a multi-purpose catheter here, which will help you to direct it towards the left innominate. And then you advance the wire all the way through. If there is any resistance, make sure it doesn't go into one of those renal veins or visceral veins. Do it under fluoroscopy. Make sure it goes all the way into the left innominate vein. Now, over this wire, you thread the transeptal sheath with the dilator. As I told you, the dilator and the sheath, the assembly should be locked. The dilator should be locked on the sheath and advance it as one unit. It will go all the way pointing towards the left innominate, and then you withdraw the guide wire. So you're now left with a dilator and a sheath. Now into this, you can see this, into this dilator and sheath, you can advance the needle, and the needle tip is advanced. Don't rotate or position as you're advancing. Let it go freely in whatever direction it wants to go. But only when you're withdrawing the whole assembly, position it at 4 o'clock or 5 o'clock position. Insert the needle into the dilator. And as you insert, right in the beginning, don't start positioning it at 4 o'clock. You just allow it to go the way along the curve of the IVC, in any way it conforms. But once you reach, you don't come out of the tip. You position the needle somewhere proximal, about 2 centimeters from the tip. And at this time, you rotate the hub of the needle so that it's about 4 o'clock or 5 o'clock in position. Mullen sheath and dilator is advanced to innominate over it takes a O32 wire placed in the innominate vein. The BRK needle is introduced into the dilator system like this. And this pigtail is in the non-coronary cusp. The wire is in the left innominate, and you're going to insert the needle and the dilator to start withdrawing it. So make sure the needle should be parked just a 2 to 3 finger breadth proximal to the tip of the dilator so that it doesn't come out. And you need to fix that distance. You should know the distance even before you take it inside the system. And maintain this distance between the hub of the dilator and the needle constantly throughout the procedure. Don't allow it to slip. Place the needle Once you're ready to puncture, place the needle between 4 to 5 o'clock position, and then you can disconnect the syringe and it can be connected to a pressure, closed loop pressure system to monitor the pressure. This is very important. Pressure guided puncture is quite simple, because if your lumen is all right, you'll be starting to record the right atrial pressure as you come from IVC to the right atrium. So the waveform will be like right atrial pressure. Once you engage the septum, it falls inside the septum and the lumen is blocked. Suddenly you find you will lose the pulsatile nature of the RA pressure. It will become flat. That tells you have engaged on the tissue somewhere, it's hitting the tissue, and you can confirm whether it's at the right position. So in LAO and AP view, keep the pointer needle at 5 o'clock position. Take care, the components don't independently rotate, you rotate the whole system. You need to pull the whole assembly from superior vena cava to RA. You'll find a first medial drift, and then as you pull down, you'll find another medial drift when it falls into the fossa ovalis. And then sometimes if the LA pressure is high, you will start feeling a pulsation of the left atrium. As the system is withdrawn caudally, you will find that the catheter tip is more aligned to the midline. And you will suddenly at some stage, the pulsatile nature of the RA pressure will be lost and you will have a flat line at that time on the catheter tip. Generally for normal LA, 4 centimeters and less, 4 to 5 o'clock position should be okay. But in very large left atrium, you may have to clock it more and get it to around 5 or 6 o'clock position to engage the septum. And again, to reiterate, this is the position of the needle we are talking about. In small atria, it will be somewhere around 4 to 5 o'clock position. In large atria, left atrium, it will be between 5 to 6 o'clock position. So let's just see some case examples. So this is under echo guidance. You have a bicable view, superior vena cava and inferior vena cava. As you pull down the whole assembly, you see that there is a tenting there. You want to puncture a little more. This is in the mid fossa. You can pull it down and make it in the inferior fossa or superior fossa, as the case may be. You can see the tent. We are drawing the whole assembly down, pulling it down, and then you need to rotate your echo probe to always keep this tenting in the middle of your screen. And depending on where you want to puncture, once you get the tenting of the fossa, you know that you're ready to go and puncture. But most of us use fluoroscopy routinely. And as I said before, when you start coming down, watch the movement as you start withdrawing from above. You're coming down. Yeah, there you saw a medial drift there. And now you'll see another medial drift. Yes, you engage the septum. And then you can rotate your IA to RAO position and LAO position to confirm you're in the right position. In left lateral or steep LAO, draw a line between the aortic catheter and the posterior wall of the left atrium. We generally choose in the mid segment, the anterior third, mid third, and the posterior third. We target the mid third and engage the septum, give a little contrast to stain the septum. You'll see the contrast is flowing this way and you need to puncture. We are seeing this coming down. The needle is just about to puncture. Yes, you're punctured and injector, you can see a little contrast being puffed there. Then you've entered the left atrium. The moment you enter the left atrium, it's important to counterclockwise the assembly gently, so that because you're initially entering in a posterior direction, you don't want to hit the posterior wall. So generally counterclockwise the sheath so that it comes a little anterior and you can engage the once it's well inside the left atrium, you can advance a wire, either a 3-2 wire well into the pulmonary vein, or you can do this wire which comes along with the mitral balloon valvotomy. You can use this coiled wire, which can be used to support the advancement. Now, this is what I mentioned. When you're in the SCC and RA, the catheter tip will be phasic. It will be a ACB wave, like a right atrial wave. And when you engage the septum suddenly, you find that you don't see the pulsatility. And the moment you puncture and you're in the lumen of the left atrium, you will start seeing the left atrial waveforms. So it's extremely useful. Only thing is, make sure the lumen is flushed and adequately the system is calibrated so that you can see the pulsatility. It's a very useful index. If you're inadvertently puncturing the aorta, suddenly it'll be out of range, because this is in 20 millimeter pressure range, and suddenly inadvertently you're punctured and the aorta is 120 millimeter or 130 millimeter pressure, it'll go out of range. So if only the needle tip has punctured the aorta, and you have not advanced the dilator or the sheath, nothing will happen. You can just pull out, don't give further doses of heparin, everything will be all right. You can puff a little contrast and things should be all right. Oh, this is. Okay. Again, you take a short axis view, aorta in the middle, in the imaging plane, and as you tent, you make sure that you're advancing the needle. You can see a tenting of the septum, intraatrial septum, and you can see a good metallic needle tenting it. And the moment you puncture and inject contrast, you'll find that there's air bubble coming into the left atrium. I'll go back through this again. So as you tent, this is a dimpled transesophageal echo-guided puncture in short axis. You can tent the diaphragm, intraatrial septum, and as you puncture, inject contrast to confirm echo. Just inject saline. You'll find before the puncture, everything is within the right atrium. And the moment you puncture, you'll find the left atrium gets, you'll see all the echo bubbles in the left atrium, telling you that your tip has crossed. The moment it has crossed, advance a tiny bit, but with a counterclockwise turn, so that you are not hitting the posterior wall. And again, this is another example. Just to say, in a short axis view, bicaval view, you start coming down. So what are the challenging situations? Sometimes right femoral vein is not the choice because it's occluded. You can get through from the left femoral vein, and only thing is it will be a little challenging to take the bend. Use fluoroscopy when it crosses. Go well inside the right atrium through the sheath and the dilator, and then if there is adequate length, then you can take the needle with the stylet, and you may have to slightly adjust the thoracic position so that the vein comes in line. If you meet the thorax a little rightward, the left internal iliac vein will be in line with the IVC. So this is what it meant. So just to straighten this out, slightly move the thorax towards the right side, and you'll find that the left iliac vein becomes in line with the IVC. So it'll be like you won't have that angulation, sharp angulation. It'll be easy to cross through. And the other thing is a little bit of telescoping technique. Have the dilator and the needle well into the right atrium, and then advance a little bit. As you are advancing, pull the dilator so that you can move and rotate a little bit on the needle and the stylet, you should be able to take it forward. In very large giant right atrium, this kind of a regular needle will not do. Most often we need to bend the needle very sharply or take a BRK1 and give a proximal bend so that you're able to engage the septum. Now, even in EP, we need to understand if you need to ablate something in the posterior papillary muscle, post-infarction VT from the inferior wall, the punctures are relatively a little inferiorly oriented punctures. And if you need to go a little anterior in a dilated left ventricle, you need to make an anterosuperior puncture. And this is important, the direction of the puncture. For routine procedures, you can make it a little more. For a PV isolation, we come from anterior to posterior. For LV entry, we come from a little posterior to anterior. So what are the complications? The most feared complication is cardiac wall perforation, pericardial effusion, and tamponade. This can be avoided by careful kind of attention to details. If you're slightly doubtful, get a TE done at the time of the procedure. If there is good tenting of the intraatrial septum before puncture, you're unlikely to cause an effusion. You can just use fluoroscopy to make sure that most of us are used to operating just with fluoroscopy, just little inferior to the aortic margin and posterior to aortic margin is a safe fluoroscopic landmark to avoid this. Aortic perforation, if it happens, please do not advance the dilator in the sheath. If it's only the needle, generally nothing will happen. Just wait for some time, puff the contrast, pull the system back. We have given heparin, immediately give protamine and reverse the heparin effect. Things should be all right. Air embolism and TIA, I've still seen some of the centers having this problem. One of the important ways to avoid this complication is hydrate the patient very well before you take up. If the intrathoracic pressure is very negative, it will suck air. So one way is to just hydrate the patient very well before you take up, especially axillary pathway mediated tachycardias. They may come overnight fasting and they'll be a little dehydrated. Hydrate well, that will prevent. Second way to prevent is when you do any kind of catheter exchanges, you pull the sheath, pull the dilator, and then take the ablation catheter. Make sure it is all done with a wet gauze sealing the back end of the valve. You sometimes, even though this brief exchanges, when the valve opens up, it will suck air. Third way to avoid is if your patient is breathing, ask him to exhale during the like a Valsalva, ask him to exhale and hold the breath so that there is no air exchange during this procedure. If you're doing it during anesthesia, we can ask the anesthetist to do a breath hold so that there is no air exchange and air embolism is minimized. That will be presenting as a transient ST elevation, generally in the inferior leads. This should be avoided. Very large sheets when we go back and forth, for example, when we take say 16 French sheath across the septum, sometimes there is patent septal defect. Generally that closes itself over a period of time. Inadvertently, rarely you may end up in a problem. If there is a tamponade, don't panic. Immediately reverse the heparinization with protamine. Keep a pericardiocentesis straight. We can just have the auto transfusion with a 50 ml syringe. And if the patient has been on warfarin or something, just immediately start giving FFP. Keep the surgeon for standby. 90% of the time, you won't need any surgery. If you aspirate well and keep giving it back into the system, after about 50 or 100 ml of blood is drained, generally the bleeding stops on its own. One of the other drug which is used in this is tranexamic acid, 500 milligram, you can give it. These are the things we do if there is any evidence of tamponade. This is a very rare complication. This is one of the things where if your needle goes through the septum, comes out into the pericardial space, and then like a stitch, it goes across. inside the left atrium, you'll finish all the puncture, everything. But only when you remove the system, you'll find the patient is going to crash. This is a worse complication. One way to avoid this is never ever make a very superior puncture, because surgeon himself will find it difficult to reach this area. And this can be avoided if your puncture is below the aortic root. Second problem is, if you think this is going on, is to leave the wire. When you pull out, don't pull out the whole assembly. Leave the wire for some time and then slowly take it out, observe what is going on. In case there is any kind of a problem, surgeon can be alerted, or you can even use a device to close this particular area. Now, this kind of a parallel staining across the aortic root, you need to be a little cautious, exercise caution, wait for some time, make sure there is no pericardial effusion. This stain, if it's remaining there, it's again serving as a landmark. You need to go a little inferior and posterior. This is an RAO. If you look at it, the plane of the aorta, you need to be a little beneath the valve, beneath the level of the valve, and posterior to the valve. Sometime here will be the site of your puncture. And in this is a patient with a very enlarged aortic root. This can be challenging because when you come here, suddenly it will fall, but it will be in this area. When you puncture, you may still enter into the aorta in very large left atrial, in very large aortic root. So you need to clock the needle more and pull the needle to a more inferior position to engage the septum and enter into the left atrium. So understand the anatomy, know the fluoroscopic landmarks, use transesophageal echo or ICE, be prepared to deal with challenging anatomy, and be prepared to deal with the complications. Thank you very much for the patient listening. I'm sorry I'm not able to be there in person, but I'm sure my colleagues, Dr. Arun Gopi and Dr. Lawrance and other members of the team will take up any questions. Thank you very much.